this lesson, we'll learn about uveitis. Uveitis is inflammation of the uveal tract. What causes uveitis? Uveitis can have many causes, including infections, autoimmune disorders, malignancy, eye injury, toxic exposure, and so on. Infections such as Shingles virus, herpes simplex virus, syphilis, Lyme disease, and parasites such as toxoplasmosis, a systematic inflammatory disease such as inflammatory bowel disease, IBD, or rheumatoid arthritis or SLE. Smoking also increases the risk of getting uveitis. The type of uveitis is classified by where inflammation occurs, including anterior uveitis, intermediate uveitis, posterior uveitis, and diffuse uveitis. Anterior uveitis refers to inflammation of the iris alone and the inflammation of iris and the ciliary body. Intermediate uveitis refers to inflammation of the ciliary body and the vitreous. Posterior uveitis is inflammation of choroid, retina, retinovascular, and intraocular optic nerve. Diffusion uveitis is inflammation in all areas of the uvea, also called panuveitis. Anterior uveitis is most common and is usually unilateral and acute in onset. The typical symptoms are pain, light-sensitive, and blurred vision. And signs include redness, KP, miosis, posterior and anterior sector, iris nodules, and hypopyon. Examination usually reveals circumlateral redness with minimal palpable conjunctival injection or discharge. Because the blood vessel expanded, the eye becomes redness. It's also called ciliary congestion. Clumps of white cells and inflammatory fibers are usually evident on the cornea endothelium. In patients with active inflammation, we name it as KP, charactic parasititis. KP may be large, small, or skeletal. KP may be granulomous or non-granulomous, depends on different causes. KPs are usually located inferiorly in a wedge-shaped region known as Archer's triangle. Serous KPs are usually distributed eventually over the anterior cornea endothelium and may be seen in uveitis due to herpes simplex virus, herpes zoster virus. Sometimes it is located to an area of period or active keratitis. Aqueous flare. Turbidity of the aqueous humor caused by increased protein levels in cells. Visual impairment depends on the intensity of the flare. Posterior stanchion. The pupil adheres to the anterior capsule of lens. Miosis means excessive contraction of the pupil. There are different shapes of posterior stanchion, a condition occurring in posterior annual synia. Then, an increase of aqueous humor contained in posterior chamber cause of forward flooding of iris. It may provoke an attack on angle closure glaucoma, as the iris may block the direction angle. Anterior synetia. The iris adheres to the anterior chamber angle and cornea endothelium. Anterior synetia causes closed-angle glaucoma, which means that the iris closes the draination way of aqueous humor, which in turn raises the intraocular pressure. Iris nodules may be present at the iris margin, called copa nodules, within the iris stroma, called Bosaka nodules, or in the anterior chamber angle, called Berling's nodules. Particularly severe anterior chamber inflammation may result in layering of inflammatory cells in the inferior angle, which is hypopine. The most common cause of hypopine uveitis in North America and Europe is HLA-B27-associated uveitis, whereas the most common causes of hypopine uveitis in Asia is Behçet's disease, and the most frequent cause of hypopine in agricultural communities in more mild parts of the developing countries is leptospora. Intermediate uveitis usually is painless. Symptoms of this type of uveitis include blurred vision of floaters, typically in both eyes. The typical signs are snowballs and snowbankings. These are snowballs in the anterior vitreous, and this is snowbank. Posterior uveitis includes retinas, retinovasculars, and papillitis. The patients can suffer from floaters, loss of visual field, scotoma, and decreased vision. The signs include retinal vein dilatation, exudation, hemorrhage, and cystoid macular edema. From the photo, we can see the dilation vein, exudation, and hemorrhage. The term diffuse uveitis is used to denote a more or less uniform cellular infiltrating of both the anterior and posterior segments, which is called endophthalmites. Associated findings such as retinas, vasculitis, or choroiditis can occur and often prompt further diagnostic testing. Tuberculosis, sclerosis, and syphilis should always be considered in patients with diffuse uveitis. Less common causes include sympathetic ophthalmia, VKH syndrome, and intraocular lymph node, and so on. How to make a diagnosis? When symptoms occur, a prompt examination by an ophthalmologist is important. The ophthalmologist will use instruments to examine the inside of the eye and can usually make the diagnosis on that basis. Since uveitis can be associated with disease elsewhere in the body, the patient will require a thorough understanding of the overall health, and this may involve the conclusion with other medical specialists. The patients may also require blood tests, X-rays, and other specialized tests to establish a cause of the uveitis. Detection of intraocular fluids has become very essential in recent years. If left untreated, inflammation in the eye can lead to pigment damage or even blindness. Differential diagnoses include acute conjunctivitis, keratitis, and acute angle closure glaucoma. Complications: secondary glaucoma, anterior synetia and posterior synetia can block aqueous outflow at the chamber angle and cause glaucoma. Both anterior and posterior chamber inflammation prompt lens thickening and opacification, complicated cataract. Treatment involves removal of the character, but should be done only when the intraocular inflammation is well controlled. Cystoid macular edema is a common cause of visual loss in patients with uveitis and may be observed in the setting of severe anterior or intermediate uveitis. Retina detachments, including traction regions and extrusiforms, occur infrequently in patients with posterior, intermediate, or diffuse uveitis. These are complicated cataract. This is swelling with cysts in macula and accumulation of dye in macula. How to treat uveitis? Corticosteroids and cycloplegic agents are the main stage of the therapy of uveitis. Doctors should prescribe a steroid to reduce the inflammation in the eye. Whether the steroid is administered as an eye drop, pill, or injection depends on the type of uveitis you have. Because anterior uveitis affects the front of the eye, it's easy to treat with eye drops. Posterior uveitis usually requires tablets or injections, depending on your symptoms. Any of these treatments might be useful in intermediate uveitis. For anterior uveitis, pupil dilating eye drops prevent synapse formation and reduce discomfort. Other immune non-spontaneous can produce many steroid side effects, such as kidney damage, high blood sugar, high blood pressure, osteoporosis, and glaucoma. Subtenual injections of TA, intraocular TA, or oral prednisone can also be effective. If the patients have a known systematic condition that may be contributing uveitis, which should be treated as well. The course and the prognosis of uveitis depends to a large extent on the severity, location, and cause of the inflammation. Severe inflammation takes longer to treat and is more likely to cause intraocular damage and loss of vision than mild or moderate inflammation. Anterior uveitis tends to respond more promptly than intermediate, posterior, or diffuse uveitis. Retinal, choroidal, or optic nerve involvement tends to be associated with a poor prognosis. Okay, that's all for today's lesson. Thank you for your attention.